Hello everyone. In this class, we'll try to learn some of the applied aspects related to respiratory physiology. Dyspnea. Dyspnea is difficult or labored breathing in which the subject is conscious of shortness of breath or it is an abnormal, uncomfortable awareness of breathing. A normal individual is not conscious of respiration until ventilation is doubled and breathing becomes uncomfortable. Real dyspnea, that is uncomfortable breathing, occurs when pulmonary ventilation is tripled or quadrupled. That is when an imbalance between demand of ventilation and actual ventilation is achieved. The basic mechanisms of dyspnea are hypercapnia and hypoxia. Hypoxia and hypercapnia result in increased rate and depth of breathing regardless of patient's subjective sensation. Increased effort of breathing or increased work of breathing, for example, in bronchial asthma where airway resistance is increased and compliance is reduced. Current hypothesis that dyspnea occurs when there is a mismatch between incoming afferent information to the brain and outgoing motor signals from brain to respiratory muscles. Some of the causes for dyspnea are where the disease originates from the respiratory system, obstruction of any part of the respiratory passage that is increases the work of breathing, for example, bronchial asthma. The disease of lungs or pleura, that is pneumonia, uh, pulmonary edema, fibrosis, pleural effusion, and pneumothorax. Then interference with respiratory movement, that is weakness or paralysis of the respiratory muscles, pain due to injury to the chest wall, ribs, or deformities of the spine or impaired movements of the diaphragm leads to dyspnea. Some of the cardiovascular causes are chronic congestive heart failure. Initially, dyspnea only on exertion, but later the dyspnea occurs even at rest. Then paroxysmal nocturnal dyspnea, which occurs in pulmonary edema because of the left ventricular failure. Some of the disorders of metabolism like metabolic acidosis, diabetic acidosis, uremia, and other causes like anemia, cerebral hemorrhage, and psychogenic causes, they are going to lead to dyspnea. Dyspneic index or breathing reserve percentage. It is a percentage of respiratory capacity not being used at a given resting minute ventilation or pulmonary ventilation. The normal dyspneic index at rest is around 90%, and hence breathing reserve is nothing but the maximum voluntary ventilation minus resting minute ventilation, that is it is around 90 liters. Dyspneic index is calculated by the percentage of breathing reserve, that is breathing reserve divided by mean voluntary ventilation into 100, where the MVV is maximum voluntary ventilation and RMV is residual minute ventilation or minute volume. This means that breathing can be increased by 90 liters, that is from 6 to 8 liters to 100 liters or more. Dyspnea is where when the index is less than 70%, which is called as dyspneic point. An example taken from a patient of emphysema will clarify this. The MVV has reduced from 100 liters per minute to 40 liters per minute, while RMA has increased 10 liters per minute to 20 liters per minute due to the respiratory stimulation by increased PCO2 and low PO2. Hence, dyspneic index will be around 50%. This means that dyspneic point has been crossed so that the patient is experiencing dyspnea. Orthopnea. It refers to the dyspnea in lying down position. Dyspnea increases when the person lies down and improves when person sits up. This is usually seen in patients with cardiac failure. Improvements of dyspnea occurs in sitting position as the abdominal viscera do not press upon the diaphragm during sitting so that the diaphragm can descend easily. Effect of gravity is that the person lies down, the venous return to the heart increases and symptoms of orthopnea flare up. When the person sits up as a result of gravity, the venous return to the heart decreases and the symptoms of orthopnea decreases. Hypercapnia. Hypercapnia is retention of carbon dioxide in the body. In these patients, partial pressure of carbon dioxide is markedly elevated. There is a severe respiratory acidosis and plasma bicarbonate may be very high, which partially compensate for the acidosis. Essential mechanisms underlying hypercapnia is inadequacy of alveolar ventilation for the amount of carbon dioxide produced. Some of the causes of hypercapnia are increased carbon dioxide production. In febrile patients, 13% increase in the carbon dioxide production occurs after each 100-degree rise in the temperature. High carbohydrate diet increases carbon dioxide production. Sorry, it is 1 degree Celsius. Malfunction of respiratory function. Hypercapnia is associated with hypoxia. Insufficiency of gas exchange, increased dead space, or ventilation perfusion mismatch. In hypoxia, due to the poor diffusion through respiratory membrane, serious hypercapnia does not occur because carbon dioxide diffuses 20 times rapidly as oxygen. Some of the symptoms of hypercapnia are alveolar PCO2 is more than 60 to 75 mmHg. Breathing becomes rapid and deep. When alveolar PCO2 increases more than 80 to 100 mmHg, symptoms due to depression of the CNS occurs, that is confusion, decreased sensory perception, and eventually there will be a coma. If alveolar PCO2 increases more than 120 to 150 mmHg, anesthesia and death of the patient may occur. Hypocapnia. The chronic effects of hypocapnia are seen in neurotic patients who chronically hyperventilate themselves. Hypocapnia has a direct vasoconstrictor effect on cerebral vessels. So cerebral blood flow is reduced, thereby leading to cerebral ischemia that lead to dizziness and paresthesia. If a person voluntarily hyperventilates, excess amount of carbon dioxide is washed out and PCO2 decreases. This depresses respiration and leads to apnea. During this period of apnea, carbon dioxide is accumulated and a fall in PO2 occurs. This stimulates respiration and normal respiration is resumed. If H plus is normal and if there is a prolonged hyperventilation, increased carbon dioxide is washed out and H plus becomes less than normal, and the condition is called as respiratory alkalosis. When H plus is low or pH is high, the proteins are ionized. Ionized calcium in blood combined with protein and calcium gets converted into bound form. When ECF concentration of calcium falls below the normal, the nervous system becomes progressively more excitable, leading to increased permeability of the sodium, allowing easy initiation of action potential. This may lead to symptoms of hypocalcemia and tetany. Asphyxia. It is produced by occlusion of airways. This results in hypoxia, that is lack of oxygen, and as well as hypercapnia, that is excess of carbon dioxide. Asphyxia occurs in strangulation, acute tracheal obstruction due to the foreign body, and in trachea or larynx. Traumatic compression of the chest wall by fall of heavy objects, that is trapped in building collapse. When newborn does not begin to breathe soon after birth, it develops asphyxia called asphyxia neonatorum. The effects of asphyxia is described under 3 stages. Initially, the stage of exaggerated breathing. This occurs due to the stimulation of respiratory centers by carbon dioxide. Breathing becomes deeper, more frequent, and more labored. The next stage is stage of convulsion. This occurs due to the spread of stimulation to the centers of brain and spinal cord. So generalized conversion appear. There is a tachycardia, vasoconstriction, rise in the blood pressure, and lack of consciousness. Then there is the third stage of collapse, which occurs due to the paralysis of respiratory centers. Convulsions cease abruptly and respiration becomes gasping character. Pupils dilate, pulse becomes feeble, reflexes are absent. Finally, death occurs by the failure of vital centers. Note that in the earlier stages of asphyxia, the knee jerks are exaggerated, but when the third stage is reached, they are entirely lost. Cyanosis. It is a clinical condition characterized by bluish discoloration of skin and mucous membrane, best seen in people with white complexion. Cyanosis is caused when more than 5 grams of reduced hemoglobin is present in the local blood. Thus, anemia, where hemoglobin is less than 5 gram percent, no cyanosis is seen. That is, enough reduced hemoglobin is not formed to produce blue color. But in cases of polycythemia vera, where there will be excess of RBC, great excess of available hemoglobin that can become deoxygenated leads to frequently cyanosis. Cyanosis does not occur in histotoxic hypoxia. There are two types of cyanosis, central cyanosis and peripheral cyanosis. Central cyanosis is due to the heart or lung diseases and is associated with hyperkinetic circulation, that is tachycardia, increase in the blood pressure, warm periphery. It occurs mainly due to the shunting of blood from right to left side of the heart, that is bypassing the lung. Therefore, oxygenation of hemoglobin is hampered, resulting in the rise of reduced hemoglobin on the blood. This condition is characterized by blue extremities, which are warm due to the hyperdynamic circulation. The site for central cyanosis is tongue and tip. It also occurs in different lung diseases where pulmonary gas exchange is affected. Peripheral cyanosis, it is due to local causes. Here, there is severe vasoconstriction due to sympathetic stimulation. Vasoconstriction in periphery leads to reduction of blood flow in the tissue while oxygen demand of the tissues remains the same. Thus, the concentration of reduced hemoglobin rises. The site for peripheral cyanosis is toes and fingertips. This can occur in peripheral circulatory failure, resulting in cold blue extremities. Note that a discoloration of the skin and mucous membrane similar to cyanosis is produced by high circulating levels of methemoglobin. So this is in brief about applied respiratory physiology. Thank you.